You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi, everyone. This is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for May 17th, 2024. This week, an Impella update, another TAVI versus SAVR trial, 2 studies on angina and PCI, another null study from REVIVED-BCIS, and 2 studies on semaglutide. First, an update on Impella. When I wrote about and discussed the danger shock trial, I made note that this was a highly selected patient population, and the positive results for the Impella should not be translated to other indications, such as high-risk PCI. Dr. Mark Petrie, who's a senior author of REVIVED-BCIS, emailed me to tell me that his colleague, Dr. Divaka Pereira, is leading a trial called CHIP-BCIS-3, which will randomize patients with high-risk PCI to unloading with Impella versus not. The primary outcome will be a hierarchical win ratio composite of death, stroke, MI, cardiovascular hospitalizations, or periprocedural MI. I will cite the clinicaltrials.gov URL, and this is great news, and thank you for keeping me posted. Second topic is TAVI versus SAVR, again in low-risk patients, but with a super interesting subgroup. This is the Notion 2 trial. The low-risk space here is crowded. We have Partner 3, Evolute Low Risk, Notion 1, and the Dedicate-DZHK6 trial. Roughly speaking, the results look really similar for the 2 procedures out to 4 to 5 years, roughly speaking. Notion 2 is the latest head-to-head comparison to be published. It's in your European Heart Journal, and it was presented at the EuroPCR meeting. It was TAVI versus SAVR in especially low-risk patients, and slightly more than a quarter of the 370 patients in Notion 2 had bicuspid aortic stenosis. The primary endpoint was death, stroke, rehospitalization at 12 months. The average age, young, 71 years, which is a few years younger than patients in the other trials. The average STS score, low, 1.1. The analysis plan was weird. It was a non-inferiority for TAVI versus surgery, and I don't know, but I think we have moved well past the time when TAVI is a new therapy. Also curious was that the authors expected a 10% rate of events in the TAVI arm and high as 15% in the SAVR arm. Now that I think is too high. Now I tell you about these estimates because it will help inform the results. For instance, in the Dedicate-DZHK6 trial, the event rates were 5.4% in the TAVI group, 10% in the SAVR group. And these patients were 4 years older and had higher STS scores. The non-inferiority margin, therefore, in Notion 2 was the difference between 10 and 15% or 5% in absolute terms. So if the upper bound of the confidence interval was greater than that, greater than 5%, then non-inferiority would not have been achieved. I'm also curious why they did non-inferiority if they thought that TAVR was superior. It'll convert the non-inferiority margins to relative risk with SAVR as the standard intervention as it was here. Then the 5% margin translates into 15 plus 5 divided by 15, or 1.33, so 33% worse. Now here was the primary endpoint, and I want you to focus on the confidence intervals. At 1 year, the primary endpoint occurred in 10.2% in the TAVI arm versus 7.1% in the surgery group. The absolute risk difference was 3.1%. The 95% confidence intervals went from minus 2.7% to positive 8.8%. The hazard ratio was 1.4. The confidence intervals were 0.7 to 2.9, and the p-value was 0.3. They also presented an important subgroup, which was the primary endpoint incidence with regular AS versus bicuspid aortic stenosis. And with standard tri-leaflet aortic stenosis, the hazard ratio between the two groups was 1, and the confidence interval 0.5 to 2.3. But bicuspid aortic stenosis, where TAVI was nearly 4 times worse, the hazard ratio was 3.5, and the confidence intervals went from 0.8 to 18.5. So my comments. First, I think the wide confidence intervals are sad. And I say sad because this was an experiment on 400 patients, and with a relative risk going from TAVI is 30% better to 2.9 times worse, we simply cannot know. The upper bound of the absolute risk difference also went from -3% to +9%, which is greater than the non-inferiority margin of 5%. So we have to say that TAVI was not non-inferior to SAVR, but we can't say anything else. Basically, the trial was inconclusive in the overall results. Now, why the authors thought they would A, see this high an event rate, and B, TAVI would be that much better with nearly a third bicuspids is quite strange to me. Had they estimated a smaller effect size or a lower event rate, then they would have had to recruit a lot more patients. That said, though, the subgroup analysis of tricuspid versus bicuspid AS is interesting. TAVI looked much worse than SAVR for bicuspids. And that goes against a fair amount of observational data, which has suggested that TAVI does okay in well-selected patients with bicuspid AS. Now, proponents of TAVI will argue that the lower bound of the 95% confidence interval for bicuspid allows for TAVI to be 20% better, but I'd counter that. That confidence interval also allows for it to be 18 times worse than SAVR. Indeed, this is the problem with underpowered trials. We want to conclude, let's not do TAVI in bicuspids given the subgroup analysis. But since the confidence intervals are so wide, it's really hard to say. What I, an outside observer, would say is that before embracing TAVI for bicuspid valves, we should have a properly powered RCT. Though, as a patient, if I had bicuspid AS, I'm not sure I would sign up for such a trial because SAVR looks so much better to me. Next topic is on angina and PCI. There were 2 neat studies on angina from the group of Rasha Al-Almi at Imperial College London, both published in JACC. The first is the ORBITA-2 sub-analysis. This was a sub-study of the ORBITA-2 study looking at 2 things: the relationship between presenting symptoms and disease severity, and the ability of symptoms to predict the placebo-controlled efficacy of PCI. The first author of this paper was Dr. Florentina Simader. Recall that ORBITA-2 was an RCT looking at the sham-controlled effect of PCI without meds to relieve angina. Patients in this trial had CAD, were stabilized on meds, then meds were stopped, then they had either PCI or sham. PCI reduced the primary endpoint, which was an angina symptom score that patients recorded on a novel smartphone app. Briefly, ORBITA-2 differed from ORBITA-1. ORBITA-1 studied the placebo-controlled effect of PCI in patients who were maximally medically managed, and it was negative. ORBITA-2 found that PCI alone, without meds, did indeed have a placebo-resistant effect. Now, the goal of this sub-analysis was to further study symptom character to disease as well as PCI effect. It's an important distinction because these days, more and more people end up diagnosed in the cath lab not because of life-altering symptoms of angina, but because of diagnostic tests like stress tests and coronary CT scans. Symptom nature was separated into categories in this study. One was called the Rose Angina Questionnaire, and to be honest, I did not know about Rose Angina. After I read the author's description of this, Rose angina is as typical as it gets: exertional, relieved with rest, mid-sternal, etc., everything. They also used other angina descriptors, things like a short form called the McGill Pain Questionnaire, or something called the MRC Dyspnea Scale. Also, I did not know about these. The results of this paper are interesting. First, there was little relationship between symptom severity and the nature and anatomic or ischemic markers of disease severity. Second finding, symptom severity did matter. Patients with more severe angina were more likely to achieve a better placebo-controlled health state. Third finding, patients who met criteria for Rose angina versus those who did not were more likely, odds ratio 1.9, to have a placebo-controlled benefit from PCI on the angina symptom score and the number of angina episodes. Patients with Rose angina were also more likely to have a placebo-controlled benefit of PCI on exercise time, CC class, and domains of symptom and quality of life scores. It's weird though, Rose angina patients did not have a placebo-controlled benefit of PCI on stress echo scores. Patients who reported guideline-based angina, which was about 2/3, also had strong evidence of a placebo-controlled effect on PCI on angina symptom score and fewer angina episodes. But the other angina scores, the McGill and MRC dyspnea score, did not have an association with placebo-controlled effects. So my comments. The authors wrote that they were surprised that symptom severity did not correlate with anatomic or ischemic severity, but they noted that this lack of correlation was not because presenting symptoms were not meaningful. Rather, they focused on it was the nature of the symptoms. Now, I don't completely agree with their first statement, but they're finding that the type of symptoms, typical angina, matters is a really neat observation. And it's important, and here is why. At least in my zip code, oodles of patients get referred for angiography for all manner of symptoms, right? Shortness of air, fatigue, atypical things, non-sustained VT. And once angiography finds disease, a stent goes in. They can't help it. Well, what the Imperial College team has shown, or suggested at least, is that these symptoms are unlikely to be relieved by PCI, that is, atypical symptoms. If the patient gets better with these types of symptoms, fatigue, shortness of air, it's likely placebo effect. Now, back to my minor disagreement with their comments about severity of symptoms not correlating with disease severity. And I can't cite any studies here, but I recall vividly being taught back at Indiana from older cardiologists that you could not exclude left main disease based on mild symptoms. I also remember cath lab conferences, many of them, wherein the fellow showed a runner or cyclist who could still put out big watts with a tight LAD or left main. So I am not surprised about the lack of severity correlation. I do think, though, that it's immensely useful that they showed that only typical angina, which in my practice is a lot less common than atypical symptoms, is the only symptom that resists the strong placebo effect from PCI. These observations, or correlations if you will, likely explain the Orbita 2 observation that nearly 60% of patients had continued symptoms in Orbita 2 despite PCI totally relieving ischemia. Why? Well, because they probably had cath, angiography, a diagnosis of CAD, PCI, and originally their symptoms were not due to the CAD. And if this happened in the careful RCT at Imperial College, imagine how often it happens in everyday U.S. cardiology where doctors get paid to find and treat coronary disease regardless of the nature of symptoms. This is a very nice paper and a great use of data from a randomized controlled trial. This same team also presented and published the Orbita STAR trial. The second study, titled Orbita STAR, was an N of 1 trial of 51 patients with CAD, and it was led by Dr. Christopher Rajkumar, also from the same team. The question was to determine whether independent symptom verification using a placebo or sham ischemic stimulus could distinguish which patients would achieve greatest symptom relief from PCI. These patients had single vessel disease. In the cath lab, each patient had 4 episodes of 60 seconds of low-pressure balloon occlusion across the stenosis. These were randomly paired with 4 episodes of placebo or sham inflation. Following each episode, real or placebo, patients reported the similarity of their symptoms in comparison with their normal symptoms. And to maintain blinding, the operator inflated and deflated a second decoy balloon positioned outside of the patient's body to recreate the sound of a real balloon occlusion episode. The symptom score had a range of -10, and that is if placebo inflation replicated the symptoms more than balloon occlusion, to +10, a balloon occlusion replicated the symptoms exactly. Then, the primary endpoint was the ability of the similarity score to predict symptom relief later after the PCI. Now, before I tell you the results, we should just pause and consider how clever this is. No one does work like this. It's impressive. The results. The median similarity score was just 3, with an IQR ranging from 0.87 to 5.25. Pause there. I will come back to that. And remember that 0 is basically no correlation. The similarity score ended up being a strong predictor of symptom improvement following PCI. A patient who had an upper quartile similarity score of 5.25 was significantly more likely to have lower angina frequency at follow-up after PCI. The odds ratio was 8, and that was compared with a patient who had a lower quartile similarity score, and here the odds ratio was only 1.31. Statistician Dr. Frank Harrell from Vanderbilt was a co-author, and the study had beautiful Bayesian statistics. And these revealed very high probabilities, 99.9% probability of a difference in how symptom score predicts angina after PCI. I mentioned the statistics thing because some may think, well, it's only 51 patients, and that would be mistaken thinking because each patient had multiple entries in the symptom score. The primary endpoint, of course, was not a binary endpoint, but a symptom score marked by daily episodes of angina. So Dr. Harrell constructed an analysis that took advantage of all these measurements to maximize the power of the study. My comments here are that these observations well complement the secondary analysis of Orbita-2. That is, if balloon occlusion replicates our patient's day-to-day symptoms, he or she is likely going to gain relief from the PCI. The more similar the symptoms are, the greater the probability of relief. This, too, explains why so many patients in studies and in practice continue to have symptoms after PCI, even though the PCI looks perfect and relieves the ischemia. And the problem is that CAD is so often incidental, and the fault is really ours for not diagnosing it properly. These two studies provide the cardiology community, I think, with a wake-up call. We need to go back to basics. Does the patient have classic angina? If they do and tablets aren't working, angiography and PCI will likely improve symptoms and quality of life because the problem is like a tourniquet. But for the vast majority with atypical symptoms and positive stress test or mildly positive troponins, the coronary artery disease is likely incidental and is best treated with disease-modifying medicines and lifestyle changes, not metal in the coronary artery. The late American writer Upton Sinclair pinpointed the challenge of translating these very elegant studies when he famously said, "It is difficult to get a person to understand something when his salary depends on his not understanding it." Seriously though, I believe the next major breakthrough in cardiology will be when we figure out a way to explain chronic coronary disease to new students, new learners, and patients alike. The funny thing is that the late Bernard Lown was absolutely right about nearly all things related to coronary artery disease. He wrote about this many, many years ago. All right, next topic, more insights from the REVIVED-BCIS trial. Another sub-analysis of REVIVED-BCIS has produced sobering results. Now recall that REVIVED-BCIS randomized the best possible patients for PCI. These were patients with left ventricular dysfunction, coronary disease that was amenable to PCI, and viable myocardium to PCI or just pills. The main trial found no difference in the primary outcome of death or heart failure. There was also no improvement of ejection fraction. No subgroup seemed to benefit, and no substudy has yet to reveal any way to find benefit of PCI over tablets in ischemic left ventricular dysfunction. This most recent substudy looked at the impact of complete revascularization in these patients. Surely, complete revascularization would make a difference. So the authors measured completeness of revascularization with both anatomic and viability guided means. and all but 30 of the 700 patients had available data to assess at least the anatomic completeness of revascularization. Now, in the main trial, complete anatomic revascularization was recommended. About half the PCI group had complete revascularization, whether assessed by anatomy or viability. So the groups were at least similar in size. Chronic total occlusion, CTO, is often figured into completeness of revascularization. That is, the operator decided it was not doable, and so that patient would have had incomplete revascularization. So compared to medical therapy alone, get this, complete anatomic revascularization did not reduce the primary outcome hazard ratio 0.90, confidence interval 0.62 to 1.32. As in the main trial, there was also no association of complete revascularization with improvement of left ventricular ejection fraction. The authors also assessed complete revascularization with viability studies, and complete viability-guided revascularization by PCI was also not associated with a reduction in the primary outcome. A secondary analysis using LGE transmurality cutoff of 25% to define viability also found no interaction with the primary outcome in the group who had complete revascularization. Okay, comments. The authors state, and I actually did not know this, that there have been no RCTs of complete versus incomplete revascularization in chronic coronary disease. Previous studies in this field, like complete and culprit shock, were actually in ACS patients. The authors also remind us that complete versus incomplete revascularization was not randomized in REVIVED. It was up to the clinician. So, patients with incomplete revascularization were sicker and had more extensive disease. But still, the healthier, complete revascularization group did not do better. Gosh, that is surprising. We should pause the treadmill or bike or walking, whatever, for a second and repeat this. Complete revascularization did not improve outcomes over incomplete, despite the fact that these were healthier patients at baseline. Now, one twist of this analysis was the viability-guided revascularization. And here is why it was nifty. Many people think functional guided revascularization is better than anatomy guided revascularizations. Proponents like the strategy because they think it's more accurate. I like the strategy because it usually results in fewer stents. Think FAME-1 trial. Anyways, the authors have this novel measure of viability guided revascularization, which assesses the completeness of revascularization relative to the extent of viable myocardium that was supplied downstream from the stenosis. In this study, the degree of functional revascularization was high at about 85%, and as I told you, no difference in the primary outcome versus tablets. So my final comments here is that this is an observational study. It corroborates and strengthens the findings of the main trial. My friends, I am shocked at how surprising and disruptive REVIVED-BCIS is. These were perfect patients for PCI. Yet the authors have not been able to find any way for PCI to look like it improves outcomes over medical therapy. I mean, how in the world does fixing proximal severe coronary disease not help these patients, even when revascularization is complete? I'm asking. I don't know. But I do know this. Professional societies, key opinion leaders, the thinkers in cardiology ought to be out there educating people that heart failure is a medical, not ischemic disease. The search for coronary disease in every new left ventricular dysfunction patient ought to be reversed. But 2 years on from the main publication of REVIVED in 2022, my zip code, and probably yours too, patients who have an abnormal ejection fraction on echo get a hotline to the cath lab. All right, semaglutide. Let me do some brief comments on 2 sub-studies of this secondary prevention select trial of semaglutide versus placebo in patients who had A, established heart disease, and B, no diabetes. Both were presented at the European Congress on Obesity in Venice. Now, Venice is a nice and unusual choice for a meeting, and I'm just throwing it out there. Maybe it has something to do with the fact that there's a lot of money now in the obesity space. Anyways, back to SELECT. SELECT randomized 17,000 patients to semaglutide or placebo. Semaglutide reduced the primary endpoint of cardiovascular death, MI, or stroke by a statistically robust 20%, hazard ratio 0.80, confidence interval 0.72 to 0.90. The average length of follow-up in the main SELECT trial was 34 months. This first substudy, also published in Nature Medicine, looked at weight loss based on baseline characteristics. It also looked at the safety and tolerability by body mass index. The follow-up of this substudy was longer at 4 years, and the main findings were that weight loss was sustained. It was about 10% over placebo on average. The weight loss was more in females, which the authors thought might be due to higher drug exposures. The report also noted meaningful weight loss in all races, body sizes, and regions. Notable was that over 40% of those in the semaglutide arm no longer had obesity at 2 years, and I remind everyone that these were patients who had established heart disease. As for adverse effects, in the main trial, an adverse effect leading to discontinuation of the drug was 16% versus 8%. In this substudy, the authors saw a graded increase in the proportion discontinuing semaglutide, but not placebo. For lower BMI classes, discontinuation rates are higher in the semaglutide arm, but not the placebo group. So, in summary, this paper adds knowledge. The drug semaglutide seems to work regardless of the baseline characteristics. Weight loss is sustained when the patients remain on it. Note that in SELECT there was not aggressive up-titration, as it was a CV outcomes trial rather than a weight loss trial. I think the second study was more interesting and well covered on the heart.org by journalist Becky McCall. Dr. John Deanfield reported results of a SELECT trial based on baseline weight as well as weight change after 20 weeks of treatment. The first finding of this was that they found no relationship between CV outcomes benefit based on baseline measures of adiposity. But the second and more interesting finding was that semaglutide reduced outcomes even when it did not reduce weight by that much. The hazard ratio for cardiovascular risk reductions was lower in both groups, albeit the group with more than 5% body weight loss had a 33% reduction in cardiovascular outcomes versus those with less than 5% body weight loss had a 15% relative risk reduction that barely made statistical significance. So my comments, like the REVIVE substudy, these studies bolster the main findings of SELECT. How you feel about semaglutide, I think, depends on what kind of hat you are wearing. If you are wearing your neutral Martian clinician hat, you look at SELECT and you see that semaglutide is a disease-modifying drug, much like statins. The risk reduction in MACE is similar, and statins are mandated as secondary prevention agents, and SELECT supports the addition of semaglutide. Although a slightly more skeptical neutral Martian would want a confirmatory trial. So I guess my thoughts on semaglutide as a statin-like disease-modifying drug turn on the assumption that SELECT would be confirmed in a second trial. But if you wear the hat of a pragmatic person who considers things beyond trials, you have a more complex view of GLP-1 drugs. You think, wait, at these prices, and with this much heart disease and obesity, we cannot easily afford these drugs. You also think, wait, if we achieve these same weight loss gains with lifestyle, could we not approach this level of MACE reduction in these patients? These are serious tensions with GLP-1s, and I'm not sure how I feel about it yet. You can let me know how you feel. So that's it for this week in cardiology. As always, I'm grateful that you listened, and if you like this podcast, please take the time to give us a rating, write us a review. These things help others find us. I'm here in Boston at the Heart Rhythm Society meeting, so I'll be happy if you come up and say hello. Tomorrow on Saturday morning, I'm doing a Hyde Park debate with DJ Laccaretti, again on left atrial appendage occlusion. I didn't ask for it, but they assigned it to me. So I hope to see you there. Until next week, this is John Mandrola from the Heart.org, Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.